Hi, guys. This is Molly Fox. I'm a respiratory therapist at Westfields Hospital. I've worked here for over 20 years, and so I've dealt a lot with sleep apnea and uh, treating those patients and kind of seeing what's next up and coming. I know I've got a few of you on here, so that's great. Obviously the first slide here is just about sleep apnea. There's a lot of anxiety about getting a good night's rest. Every household is a little bit different. Sometimes it's the opposite of what the picture that's listed here. So the first thing I'd point out is that, this does not have to be you. What we have common in the household is that sometimes people end up in separate bedrooms even because people need to get their sleep. And nobody's getting sleep in this situation. What do we got here next? Okay, so what is sleep apnea? So sleep apnea is sometimes can be, it's very underdiagnosed first. A lot of times people don't realize that their loved one next to them is struggling at night because they're asleep. This is what an obstruction would look like. So this is supposed to be nice and open here, and basically the air is supposed to go through here. And what can happen is your airway, if it totally closes off, that's what you'd call an obstruction. So that's the obstructive sleep apnea part. You can also, so there's three different kinds of apnea that you can have. The hypopneas, which would be hypo in Latin means small, and pnea means breath. So a hypopnea is a small breath, which can still lead to some sleep disordered breathing. So that would be your airway doesn't totally close off, but it closes off just enough so that only a little bit of air gets through. And sometimes you hear a small breath, which still wakes the person up to take a big breath in, and then they go back to do it again, those small breaths. And those small breaths are what is the deceiving part, because people listening to somebody sleep at night think that, they're breathing, they're just fine, when actually they're not. So they're still not breathing enough to get into REM sleep and to get into good sleep. So we've got the obstructive apnea where it's totally closed, the hypopneas, which are those small breaths, and then we can also have what they call central sleep apnea. So the central sleep apnea is your airway is actually open, but your brain forgets to tell you when to breathe. So that also is a sleep, disordered breathing. Okay, I think we covered it. So that there's a lot of people that you have maybe know that have passed away with contributing factors being sleep apnea. The latest one is Carrie Fisher. You guys all know her as Princess Leia. So Business Insider said that the coroner's officials believe that sleep apnea had to do with her death, or untreated sleep apnea. I'm sure that the other things she had on board did not help her either. But Reggie White, he's one of my favorites. But he passed away in 2004 at 43 because of a cardiac arrhythmia. So if your brain isn't getting enough oxygen at night, it's a lot easier to have a heart arrhythmia happen. Which can lead to a blood clot, which could lead to, heart attack. Sometimes I've had patients that have their oxygen drops to 65% at night, and they had no idea. Now Reggie White's family, they have actually got this Reggie White Foundation going, so that if people that can't afford to be treated with CPAP, they'll you hook yourself up with that foundation, and they've been advocates for helping people get treatment. So the three strongest predictors of risk for sudden cardiac death are being 60 years or over, having low blood oxygen levels, and having at least 20 episodes of apnea per hour. And a lot of people are in that range. So basically, they kind of classify sleep apnea. If all those apneas events that we talked about, the apneas, the hypopneas, and then the centrals, they take all those that you have, and they divide it by how many hours you slept, and they come up with what they call an apnea-hypopnea index. So that's so if you wake up less than 5 times an hour, then you're considered within the normal range. If you wake up 5 to 15 times an hour, then you're mild sleep apnea. 15 to 30 times an hour would be moderate sleep apnea, and then anything above 30 is usually considered in the severe range. There's a lot of things that go along with sleep apnea, a lot of diseases, but also a lot of symptoms. So one being unrefreshed sleep, decreased concentration, night sweats, frequent awakenings. These things here, memory loss, attention deficit, depression, anxiety, diabetes, like I said, arrhythmias, those are a lot of diseases. And the symptoms too, tossing and turning at night. Some people, it looks like a tornado hit their bed when they wake up in the morning. They probably have sleep apnea. They see it in, all over the world. People that go to a sleep lab, they toss and turn, they put the CPAP on, and then the people don't move for the rest of the night because they're finally getting rest. People will have to get up and use the restroom 2 or 3 times at night. Generally, that's not a normal thing. You can have other issues too, of course, but a lot of times sleep apnea creates more urine in your body, and then one of the apneas would wake you up, and then I must have to go to the bathroom. So then you'd use the restroom, come back to bed, and then do it again later. Morning headaches can definitely have to do with the low oxygen at night. Snoring, of course, and waking up with a dry mouth. Lots of bad things can happen with that. The Epworth Sleepiness Scale is just, if you guys can look that up, this is, what chance do you have of dozing? If you're sitting and reading, how likely are you to fall asleep? So 0 would never doze, 1 is slight chance of dozing, 2 is moderate chance of dozing, 3 is a high chance of dozing. So basically you'd answer that to all these questions here. So if you're in a car, hopefully you don't stop, or hopefully you don't fall asleep. But a lot of people don't realize that taking naps every day is not normal. Being able to watch TV in the evening, most people can stay awake for that. So those things, they say basically if you have a score above 7, you should come in and have that addressed. You can also not have very many symptoms and still have significant sleep apnea. So if you say, well, I'm not tired, well, if you end up with a hotel room with some of your girlfriends and they're like, well, we cannot sleep with you, you probably have sleep apnea too. I've heard it all. Some of the testing that we do, like it would be the home sleep test. This was kind of what that looks like. Basically, your doctor has to order, a sleep referral first, and then that sometimes your insurance dictates what kind of test that you should have done. Sometimes the home sleep test is more of a screening tool, partially because we don't do an EEG during the home sleep test. You can't go ahead and put an EEG on yourself at home, but this would be they're monitoring something. So there's a chest binder and there's also an abdominal binder. So that will measure every breath that you're taking and all the times that your abdomen moves. It's also checking your blood oxygen level and your pulse, and then it's also measuring your airflow. And based off of all those things, a lot of times they can detect those shallow breaths and then the obstructive apneas. So it's harder for it to assess hypoventilation because we're not checking end tidal, and because we're not doing an EEG, we can't tell what stage of sleep you get into. Sometimes we can kind of guess that when you have the most sleep apnea, occurring, that you might be getting into REM at that point. But sometimes people don't get into REM at all because they have that sleep apnea too. And this is what would show up for the home sleep test. So we've got, the rhythm of your heart. We've got, the pulse rate. And then this would be, basically those are it looks like an apnea here. So that's when you stop breathing and then you take some big breaths in, stop breathing, some bigger breaths again. and how long these. Sometimes it'll tell you about exactly how long you stop breathing for. I was meeting with a woman earlier today, and she stopped breathing for over a minute at times, and I mean, she didn't believe me until I showed her study. So it's kind of cool that, you know, sometimes when you see this and this is you, it brings it all home and makes sense. This is more what the in-lab polysomnography would look like. So this is where they do the EEG. They have those patches all over your head, and they can tell exactly what stage of sleep you get into. Those are all hooked up to this box here. So they still have the chest binders and the abdominal binders, and they are also checking for limb movements. So they're checking your arms and your legs to see how often those are moving. Because sometimes the sleep apnea, when you wake yourself up, that's when you move. So a hypnogram is kind of one of the, you know, I go over this with patients too when they come visit me. So this would tell you at the end of your sleep study what, you know, what stage of sleep you were in, where you were, and what was going on. So the first part, the hypnogram, this is when you're awake, and then this is stage 1 of sleep, stage 2, stage 3, and then this person got into REM over here in that green here. Your body position, so this is if you're on your back, if you're in supine, and then this person was on the right side and then they're back most of the night. So they kind of were in and out of sleep. The sleep techs are under some strict criteria where they need to get 2 hours of recorded sleep time before they can usually apply treatment to a patient. These are the respiratory events, so every little tick mark here is an apnea or a hypopnea. And then this person had a lot of limb movements. So all these little tick marks here, that every time they moved. So there's a lot here. This person did get some CPAP applied to them. They had a lot less limb movements here. And then you can also see that this is probably where their pressure was probably the best at, because that's when they got into REM and they had the least amount of events. They didn't necessarily like, this was when the sleep tech was playing around with a couple different pressures to see if they could get rid of all the events. But so that's kind of, that's when the CPAP was applied, and then this is the oxygen level down here. So we can kind of look at the whole night on one page. But I usually, it's kind of fun to go over that with the patients too. You know, some of the health concerns that go with sleep apnea, like they said, the cardiac arrhythmias, diabetes is definitely one thing, and like anxiety, depression. If you don't sleep good, your body is not, you know, happy. It can cause some anxiety, depression, mood disorders. Because if your organs don't sleep good, they're not going to perform well during the day. They're supposed to be resting, and they're actually like running a marathon. These for diabetes, so the consequences of too little sleep, or too little of stage 4 sleep, I guess. It impairs your blood sugar metabolism, increases your appetite, linked to weight gain, increased cortisol level, insulin level decreases, growth hormone decreases, shifts in hormone levels. So there's a lot of different things that happen for diabetes too. A lot of times we'll get patients that have high blood pressure. They'll come in, they're on 3 blood pressure medications. They get treated for their sleep apnea, and sometimes they can decrease the amount of blood pressure medications they're on. For people with diabetes, they'll be, you know, on 3 different medications, and we're able to decrease some of the amount of medication that they need. And that's why we have you follow up with a sleep doctor for sure, because they're really good at, you know, weighing out and, okay, it looks like we can kind of look at this and go down on this medication, and that's why we have you closely follow up with the sleep doctor. So all of our sleep studies are read by a doctor that's certified, board certified in sleep. So then I was talking about the AHI. That's how often the person wakes up every hour, and we were talking about which ones you can have. So this one was, I think this was Dr. King Biggs had read this one, but this is what the report would look like after they do their analysis. So this person had 1 obstructive apnea. They had 51 hypopneas, and then basically they end up waking up about 22 times every hour, that apnea-hypopnea index. Their oxygen dropped about 80%. So it looks like this person was put on CPAP, and then the suggestion was to be put on 8 centimeters of water pressure. That's how we determine how much pressure they need to keep their airway open. And it looks like they don't need any treatment for their limb movements. So that's kind of what that report would look like. Treatment options for sleep apnea. So the best treatment that we know is a CPAP machine, and basically they've gotten really compact, and all the machines now have modems, so they can report back to the DME company how you're doing, and because we want you to be successful. We want to make sure that your insurance company wants you to use this machine because they know that you're going to be healthier by using this machine, and that's where we're at with technologies. Now, this machine, either of these machines will call in with the internet every day, and if there's a problem, it will dump to a list, and the DME company will call you and say, hey, it looks like that the apnea-hypopnea index is still elevated. We're going to call your doctor and see if we should change that pressure. So that's kind of one of how that works. And patients actually, they can, from apps on their phone, they can actually look and see, oh, it looks like, I'm doing really well. So they have access to that information as well. This is one of the masks, one of the smallest masks that we have out there right now. This one's a pillow mask. So some people don't realize I tried CPAP before. The mask was way too big. The machine was so loud. The machines, you actually can't hardly even hear them now. And the masks have gotten really small. So I hate to have somebody say, well, give me one of those excuses, because we've made a lot of advancements in the last 20 years. So this is some of the reports that we can get back with the technology that we have now. So this one would be the AirView. So this person has been using, this is how each day that they use their machine. So all the green, insurance companies want you to use this for at least 4 hours a night, 70% of the nights, to say that you're getting some benefit from your equipment. We want you to use it every night, all night, because we know that if you're not sleeping with the machine, you're not sleeping good. REM usually occurs in a few different chunks during the night, especially earlier in the morning, right before you get up. It kind of tends to be the longest chunk, and it'd be great if we could get all those chunks of REM to make you feel the best. But it tells us basically what the apnea-hypopnea index was over the last month, so 1.7 is okay. So anything under 5 is kind of what the goal is. So if it's 1.7, that's really good. This person skipped a night or two here, but really that's 87% is considered compliant, and it could be that maybe they were traveling, and sometimes people nowadays have like a machine that they travel with because people get lazy, but it's just convenience. It's the world we live in. Technology with the downloads. So some of the newer machines where to diagnose an issue, a patient would call into the durable medical company and say, hey, this night this happened, and we can actually see every breath that they breathe during the night, which sometimes is overkill. It's like, do we need to know all this? But sometimes there's some good data that we can kind of look at. Oh, the mask seal was bad, or they were in a high leak, or, we need a new mask fitting, stuff like that. Other options would include surgical pallioplasty. So this is where they would go in with a laser, and they can cut that area out right there and then make that more open. Sometimes that works, sometimes it doesn't. Sometimes it is partially effective. So if your apnea-hypopnea index is 30 times an hour that you're waking up, if you had this surgery done, it would maybe cut it down to 15 times an hour, but then chances you still have sleep apnea at that point. So it's not always, it might help, but it's not always the best treatment. We have to retest you to see if it actually improved you or not. The oral airway appliance, I guess it's also another option, because what it does is it draws your bottom jaw forward, and it basically makes this space bigger so that it's less likely for your tongue to fall back and cut that area up, make that area closed off. I've had a couple patients come back in after they've had this oral airway appliance really upset because they maybe it's because they didn't do the exercises after they had that completed, but they end up with braces again. One gal I had locked jaw, so I'd rather have somebody go with the CPAP if they can't get used to it than maybe move on to the next thing. I've had some people question me about that Inspire, and I guess I don't know. I know that it's a surgical procedure, and they put the stimulator, that it stimulates your airway to keep it open. I would be cautious with that too, because I don't know that stimulator, if that would prevent you from getting into REM sleep, then it's not going to be effective either. And you'd have to really be retested in order for that to show benefit. And it still would freak me out to have that done. How much sleep does a person need? A study done at Chicago University showed that healthy men restricted 4 hours of sleep for 6 consecutive nights lost 30% of their ability to secrete and respond to insulin. So that's especially if you're diabetic, that's really bad. You need to get more sleep than that. Somewhere between 7 to 9 hours per night is suggested. Like I was saying, normal sleep consists of those 4 stages that cycle through the night. Usually you get into the, stage 1, stage 2, stage 3, and then REM, and then you do that a couple times. And like I said, the longest cycle of REM is usually the last one. Stage 1 is lightest and progresses to stage 4 into REM or rapid eye movement, which restores and repairs, you to become feeling rested. Questions. So at this point, we'll check the chat box here and see if anyone has had any questions. I don't see any yet, but feel free to take a second if you'd like to put in a question. Otherwise, that's kind of what I have for you. Like I said, I'm at Westfields. I know we take care of patients in Hudson and Lakeview as well. And I know that the Durable Medical Equipment Company runs in St. Paul. They're at the specialty clinic. And then a lot of my partners over at Lakeview and Hudson and Westfields here too. We all are available a couple different days during the week, just to kind of suit the needs of make sure we get people taken care of. Here's okay, hold
on. My question is, how many beds do you have at Westfields for sleep studies, and what nights do you do them?
Okay, good question. So at Westfields, we have 2 in-lab sleep study rooms. And usually we run the lab open 2 nights a week. A lot of times it's Mondays and Tuesday nights. Different nights of the week, like I said, Maplewood I think they run sleep studies every night of the week, so we'd hate to have that deter someone from getting a sleep study done. The home sleep tests, we can set pretty much up any day. They take about an hour appointment. It doesn't actually take that long, but for the patient time, it's about a half hour. Show you how to use the equipment. You bring it home, and then you bring it back the next day once you've worn it. So those are a lot more flexible.
Just a reminder, if you have a question, there's a chat. You can type them in. We're just going to wait another minute for questions, and if we don't have any, we'll just close out the webinar. And wanted to thank you for attending too. See, we do have a question. I'll turn it back over to Molly.
Okay, well, the one question that's here, it says, what do doctors base their decision on whether to authorize a sleep study or any other tests? So a lot of times it's just the patient will come in complaining of tiredness, complaining of snoring. Insurance companies like to see that documented when the patient's seen by the doctor. Insurance companies don't want to just do them, pay for them willy-nilly. So a lot of times if those things are written down, daytime fatigue, a lot of times there's other, like high blood pressure, anxiety, depression, a lot of those things. Well, they will, right now what the Valley hospitals are doing is they'll write a sleep referral service order, and then that'll go to Maplewood, and Maplewood looks at that and looks at the doctor's documentation and looks at the patient's insurance. And sometimes, like I said, the insurance companies want to pay for the home test, and then go from there. And sometimes the insurance companies will order the in-lab study. So it doesn't take much really for them to order a sleep study.
All right, thank you all. I don't see any other questions coming through. So again, thank you. I will send out an email with the slides and the recording to you. And again, appreciate you attending with us. So we'll sign out now. Thank you.